I'll be writing down questions from the chat box. Okay. So as soon as questions come from the chat box, I'll go on writing. Okay.
Dr. Johnny, please let people in. Huh? I'm going to get that live thing done. YouTube.
Five minutes to go.
Jason, good evening.
Good evening. Hi. That's Dr. Narayanan, President of the IAP Kerala. Anil. Narayanan, have you met Anil Vastavan? Anil Vastavan is the one in the beard.
Yeah,
Raise your hands, Anil.
Yeah.
Yeah, you know it. Mahesha is the renal pathologist. He's raising his hand there, young boy.
Yeah.
Yeah. Yeah.
Not
Rest
more.
of them you know. You know Anil Matthew, you know the rest.
My head's
Anil Matthew,
always there. Hi.
Elizabeth ma'am, my teacher.
Yeah.
So nice that IAP Kochi has taken this topic.
Yeah.
And with so many experts coming in.
Okay. So, time lag now.
We have 1 minute. We start in 1 minute.
Have we 1 minute left, huh? I'm trying the video. Just see if it shares. Is it coming on?
Sir, video vanda, sir.
Is it coming on? Just see.
No, it's not coming on. Sir, 7 o'clock, shall we start?
Yeah, I'll start recording also, isn't it?
Yeah, do. Please. Listen, sir.
Yeah.
Shall we start?
Yeah, start.
Good evening, everybody. Welcome to the third of the Pediatric Potpourri series conducted by IAP Cochin branch in association with the IAP Kerala branch. Today we have a very interesting topic, nephrotic syndrome. A not very common but can be tricky topic, and we have a galaxy of speakers, experts in the field who are going to enlighten us in the intricacies of its management and diagnosis. Over to Dr. Jason for the proceedings. Thank you.
Thank you, Pramod. That's President of the IAP Cochin branch. We have our IAP State President, Dr. Narayanan, with us. Please raise your hands, Narayanan.
Yeah.
Yeah.
Good evening.
Thank you for being with us. So we are today going to dissect nephrotic syndrome. We're going to lay to bare open, and we got great experts to deal with this. First of all, we'll have Dr. Anil Matthew. Please share your slide, please, Anil. Anil Matthew is a nephrologist at the Amrita Institute at Edapally, AIMS at Edapally, and he's going to talk about childhood nephrotic syndrome as a scenario, and he's going to talk about the initial management of sensitive nephrotic syndrome. And he did his MBBS at Potpourri Medical College, and then he was at Manipal for his MD and DNB, and did his ANIO certification and renal pathology. He's presently the clinical professor of pediatric nephrology at Amrita Institute of Medical Sciences. Over to you, Anil, to start the proceedings for the day. All the best.
Good evening to all of you. Nephrotic syndrome in many children is a right of not only relapses and remissions, but also stress and relief to the patients as well as their families. It requires the management of complex medication regimes along with ongoing ANS monitoring of the patient. Highlight the challenges we face. Let's go through a case scenario. A second order girl child of non-consanguineous marriage couple. She was a preterm baby with very low birth weight, the significance of which we will see in future slides, future presentations. She first presented at the age of 1 year, 10 months with anasarca. There was no hypertension or renal failure, but she had microhematuria. Urine showed a nephrotic range of proteinuria with a significant hypoalbuminemia. She had very high serum cholesterol levels. She had hyponatremia. Her serum complement C3 was normal. She had nothing to suggest a secondary nephrotic syndrome in history or examination. So at this point, biopsy was not indicated. So we considered a provisional diagnosis of primary idiopathic nephrotic syndrome. She was started on steroids and Manda was tested, it was negative. She took about 3 weeks to respond to steroids. So it was termed as a steroid sensitive nephrotic syndrome. She had severe hypercholesterolemia, but we were expecting it to come down as soon as she attains remission. So it was not treated with any medication. She was advised a reduced amount of oils and fats in diet. That's all regarding hyperlipidemia. Hyponatremia is often spurious. It's probably because of the hypercholesterolemia. Multiple other reasons also could be there, but it is often it's spurious and does not need any treatment. She was given prednisolone 60 milligram per square meter body surface area 6 weeks, followed by 40 milligram per square meter body surface area on alternate days for 6 weeks, tapered and stopped over the next 8 weeks. Regarding the usage of steroids in the first episode of nephrotic syndrome, there are different recommendations. All of us are aware and a bit confused regarding the exact which regime to follow. Maybe I'll suggest we should follow one regime and stick on to that. I'm following ISPN regime, which was
I'm listening to this.
Proposed in 2018, and we'll in the 2012 KDIGO recommendations, it was 6 weeks of daily steroids followed by 6 weeks of alternate day steroids with tapering of the dose over the next 2 months. So the total of 12 weeks duration treatment in ISPN recommendation in 2008 was increased to a total of 12 months duration by the KDIGO recommendation. But KDIGO guideline in 2018, which compared, Cochrane review also compared multiple studies, and in studies with low risk of bias for allocation concealment, they found no difference in the number of children developing frequently relapsing disease when corticosteroid therapy for 5 or 6 months duration was compared to 3 months duration. And while dosing steroids, dosing per body weight results in a lower total dose compared to the dosing per surface area. Whether is there any clinical relevance for both these methods? We are still not sure. Single morning dose or divided doses, again, morning dose is preferred. Actually, no higher risk of gastrointestinal adverse effects with a single dose. In KDIGO 2018 guidelines, they found that in studies where they use single corticosteroid dose may decrease the serious adverse effects compared to a divided regime. And often these children are significantly edematous, and sometimes it becomes really difficult to treat the edema, where we have to go for the step care approach. Initially, in the beginning, we can go for salt restriction as well as fluid intake restriction. Then furosemide is started, increase the dose of dose as well as frequency of furosemide in the next step, as well as change from oral to IV. Then in the fourth step, we can add thiazide, metolazone, or spironolactone. If further hike in treatment is required, albumin can be added along with the IV furosemide, albumin infusions to be used. Then furosemide can be used as an infusion after an initial bolus. And if still no response, we can go for ultrafiltration. So we'll continue with our case. So after the initial remission, she presented in relapse 3 weeks after stopping steroids following an upper respiratory infection. At the same time, she had severe abdominal pain with recurrent vomiting. First thing that comes to our mind in such a child is spontaneous bacterial peritonitis, but her CRP procal cultures, nothing was suggestive of sepsis. Ultrasound, in fact, showed no significant ascites. Then renal vein thrombosis was ruled out. Even pancreatitis was ruled out. But she just improved with albumin and diuretics. This is a common setting. Regarding the use of steroids in relapses, again, there are various regimes, ISPN and KDIGO. It's in the initial initial days of treatment, the difference is we can follow one of the regime. I am still following the ISPN regime of 2008. And in KDIGO 2018, they have found that the use of daily steroid therapy compared to alternate day, if a child is frequently relapsing, sometimes we'll be forced to taper the steroids on a daily regime than to go for alternate day. So following relapse, she was restarted on prednisolone in full dose, achieved remission after 4 weeks. She took 4 weeks. However, developed a relapse while on prednisolone, 7.5 milligram on alternate days. She was restarted on full dose steroids. Then again, she took another 4 weeks to achieve remission. This time we tried a daily tapering. However, developed second relapse while on 5 milligram per kg, 5 milligram per day. So she was a high dose steroid dependent nephrotic syndrome. Before going to steroid sparing agents, actually the option of renal biopsy was suggested and the parents agreed for to go for a renal biopsy. At that point, it was not absolutely essential, but we thought if we have to use CNI before that, better to get a histology and rule out features of chronicity. And renal biopsy, in whatever sample we got, it was suggestive of a minimal change disease. She was started on cyclophosphamide, but had to be stopped as she developed a lower respiratory tract infection and had to be hospitalized. She was treated with IV antibiotics, albumin infusions, diuretics under close monitoring, and slowly she recovered. But we didn't continue with cyclophosphamide. She was started on cyclosporine at 4 milligram per kg per day in 3 divided doses, along with the steroid. And trough levels were monitored. Those adjusted with the diltiazem augmentation. So the use of diltiazem, when we add, we can reduce 30% of the dose of cyclosporine. Steroids were tapered and stopped, and she continued to be in remission for 6 months on cyclosporine. She developed a relapse with upper respiratory tract infection. When we checked the level of cyclosporine, the level was low. Target levels were achieved with increasing dose, and remission was achieved after starting steroids. But steroids could not be tapered below 5 milligram per kg, 5 milligram per day, or 7.5 milligram on alternate days. She continued to be on high dose steroid dependent. She developed 2 more relapses requiring hiking of steroid doses. by the time she she developed headache with blurring of vision. We wanted to rule out a cerebral venous thrombosis. MRI brain was done with the venogram, but there was no evidence of cerebral venous thrombosis. Cataract was checked and ruled out. Fundus showed no papilledema, but she had raised intraocular pressure. Probably it was steroid-induced glaucoma, and she is getting treatment from the ophthalmologist for the same. And with this many months of cyclosporin use, she developed significant hypertrichosis. Cosmetic side effects were quite significant. And she had to be shifted to Tacrolimus, but on Tacrolimus, she developed high blood sugars. And we were serially monitoring her creatinine. The calculated GFR, eGFR was slowly reducing. It was found to be 40 ml per minute. At this point, a reduction in GFR could be probably a progression of the chronic kidney disease, an AKI, or drug-induced renal dysfunction. She was advised to repeat renal biopsy, but the parents were not willing. So we had to give her injection Rituximab. She received 2 doses of injection Rituximab, but the proteinuria was persisting. 2 more doses were given, and she achieved remission. And while being given Rituximab, her CD19 counts were monitored. But after about 4 weeks, she developed low-grade fever with severe leukopenia, probably a viral infection. We had to keep her in hospital for nearly 3 weeks. Slowly, she recovered with supportive measures and GMCSF. Now, for the last 6 months, she's off steroids and CNIs, continues to be in remission, only on a small dose of mycophenolate, monitoring her renal functions quite closely. And she's being planned for management of chronic kidney disease. Risk of further worsening of the renal functions and possible need of renal transplant in future were discussed with the family. Now, with this background, we can hear from our experts regarding the various intricacies related to the management of difficult nephrotic syndrome.
Thank you, Dr. Anil. We will now have Dr. Susan. He's going to talk about the steroid dependent and steroid frequent relapses. She's the, can I have a biodata slide? She's an additional professor and HOD of the Department of Nephrology, Pediatric Nephrology at the Medical College Trivandrum. She's an honorary consultant pediatric nephrologist at Sri Chindra Tirunal at Trivandrum and member of the Board of Studies with Kerala University, a faculty in the Institute of Management, Government of Kerala. Her special interests are CKD, pediatric CKD, and dialysis. I welcome Dr. Susan to talk on the steroid dependent and relapses. To you. Susan, can you unmute yourself? Susan, you're unmuted. Can't hear you.
Yeah.
Go from the first slide. Now, yeah, we can't. Can you say something?
Yeah.
Hello.
Thank you, sir, for that nice introduction. And I would like to thank IAP Cochin branch as well as IAP Kerala for this opportunity that is given to me. And hearing the problems of the child the Anil has presented, we have already learned how a dependent nephrotic syndrome can be sometimes really difficult to manage. I'm having the story of an 8-year-old boy who was brought to the OPD with puffiness of eyes and feet, and he had cough and cold 3 days back, and he has been on prednisone on 15 milligram alternate daily for the past 2 months. He was diagnosed to have nephrotic syndrome at the age of 2 years and had multiple relapses since then. He was never off medications, and whenever medications were reduced, he will relapse. The mother also feels that he has stopped growing and had gained weight after starting the medications. On examination, he has facial puffiness and pedal edema, and his height is below the 3rd centile, and he is Cushingoid. His blood pressure is also high. And so we are dealing with a child who has been a nephrotic from the age of 2 years and on steroids for a long time. So the story of idiopathic nephrotic syndrome, it is actually a spectrum of disorders which is not distinct clinically. It varies from minimal change disease to FSGS. The non-relapsing variants we actually would like to treat and be happy with the parent and the child. So also is the infrequently relapsing problem. And frequently relapsing and steroid dependent, as well as the worst steroid resistant scenarios, they can be considered as difficult nephrotics. But when we consider everything together, we will be telling that steroid sensitive means a good prognosis. So the frequently relapsing and steroid dependent nephrotic syndromes actually come under the umbrella of steroid sensitive nephrotic syndrome. But are we having difficulty in dealing with these people? So let us see what is SDNS and what is FRNS. If there are 2 or more relapses which occur in the initial 6 months after the diagnosis, or more than 3 relapses in any 12 months after the onset of the illness, any 12 months. So during any of the course, when 3 relapses are there in 1 year, more than 3, you have to consider them as having a frequent relapse. And this constitutes around 25 to 30% of all steroid sensitive nephrotic syndromes. Steroid dependence is when you have a child who has responded to steroid and you are trying to taper and stop the steroid. The child is relapsing. 2 consecutive episodes like that is there, and the child is either on alternate day steroid, just shifted to alternate day, or within 14 days of discontinuation of the steroid, if the child is relapsing and such 2 episodes, consecutive episodes are there, we are diagnosing steroid dependent nephrotic syndrome. That also contribute to 25 to 30% of all steroid sensitive nephrotic syndromes. So altogether, 50 to 60% of children who are steroid sensitive can be having a difficult nephrotic syndrome. The management approach is similar, but is the distinction important and is the distinction possible? Sometimes it is really difficult to differentiate, but usually what is seen is the steroid dependent nephrotic syndromes, even without an infection, as you come down on the dose and reach the threshold level, the child will relapse within 14 days or stopping the steroid even without any infection. Frequent relapses are usually precipitated by infections, and you will not be able to really identify a threshold dose. It is usually an infection-induced relapse, and when you count the number of relapses, you will be making a diagnosis of frequent relapses. So can we identify a child with difficult nephrotic syndrome at the onset itself? If we are able to do so, we can actually prognosticate and also counsel the parents regarding the problem. So any child with onset of nephrotic syndrome below 3 years and clinical presentation, which is consisting of microscopic hematuria, presence of hypertension and azotemia at the time of onset or during episodes. And the treatment outcome in the first episode is also important. If there is a delayed time to remission, that is usually if the remission occurs within 14 days and you call it as early response. But if it is a delayed response, that is the child is responding only after the 3rd week, after 20 days. And the second thing is you are able to maintain a sustained remission. If that is not possible and occurrence of an early relapse within first 6 months of initial treatment, that is also indicating that this child is going to have a difficult course that is to follow. The low birth weight, the Anil's child was having a low birth weight. That low birth weight also significantly increased the child's risk of FRNS, SDNS, and even steroid resistance. And requirement of add-on immunosuppression also increases or predicts the frequent relapses and dependence. And the management options, what are those options which are available to us? A good number of drugs have come up recently. And previously, I remember we were having steroid and steroid alone. And all these children used to be so Cushingioid all the time with the growth failure and short stature. But now we are having a lot of molecules which can be tried. Is a referral needed? The indication for referral is significant steroid toxicity, the relapses which are severe, that is episodes of hypovolemia, acute kidney injury, severe infections, thrombosis, or child and the family who is showing a poor compliance or a difficulty in keeping a good follow-up. These are all the situations where you have to take the help of the experts. Then the Indian Pediatric Nephrology Group guidelines is actually very good in looking at how these children can be managed. we have to find out which is the dose that is going to keep this child in remission once you have induced remission with the usual protocol-based management. And so find out by slowly reducing the dose on alternate day. Every 2 weeks you come down on the dose and identify the threshold dose. If the threshold dose is less than 0.5 to 0.7 milligram per kilogram on alternate day, and the child is not showing evidence of steroid toxicity, usually at this low dose, the child may not develop steroid toxicity. And you have to continue that particular dose for a period of 9 to 18 months before you venture on stopping the medication. But if the threshold dose is more, that is more than 0.5 to 0.7 milligram, or the child is showing steroid toxicity, we have to think of non-corticosteroid therapy. The molecules which are there are Levamisole, Cyclophosphamide, Mycophenolate, Mofetil, Tacrolimus, Cyclosporin, Rituximab, and few more molecules which may come into this list in the future. The steroid complication is actually a menacent. You can see that how this spine abnormalities can be there, compression fractures of the spine, the striae, the cataract, the increased intracranial pressure, all these problems, and the growth failure and the short stature and the Cushingoid looking child who is actually having such a bad body image and the psychologically so much upset the family. All these problems are because of the steroid. So we have to get off the steroid as much as possible or reduce the dose. And how is it possible? So there are certain recommendations which have come up in the UpToDate. That is, they suggest Levamisole as the initial steroid sparing agent. And in our experience, we have seen that this molecule is the least expensive and least toxic of all the choices that are there. And it is good for children with frequently relapsing nephrotic syndrome, as well as borderline or moderate or intermediate steroid dependence. Very good molecule. The only problem is may not be very effective in high dose steroid dependent nephrotic syndrome. But the limited global availability, this molecule is not available in US, and that is why most of the guidelines which are coming from the West may not show Levamisole in their list. But this is a good molecule and good that it is available in India. The second is Mycophenolate Mofetil, which is the initial drug if for patients with significant steroid toxicity if Levamisole is not available. This molecule is less nephrotoxic. That is an advantage. But the infection risk is more, and we have to monitor the blood counts. And MMF is not as effective as the calcineurin inhibitors, but it is a very good molecule in some of the children, at least with high dose steroid dependent nephrotic syndrome. You can sometimes get off the steroids. Then calcineurin inhibitors as a group of molecules can produce sustained remission, but the problem is a prolonged treatment that is required and the risk of potentially irreversible nephrotoxicity and the plasma creatinine concentration which has to be monitored regularly. And renal biopsy should be done as a screening measure for after 18 to 24 months to look for any renal injury. And there is one new thing that has come off in the last few years. That is, as infection is the relapse trigger, we can give stress dose of steroid during infection. Viral infections are the documented trigger, and a short-term increase to daily maintenance dosing using the same dose that was given on alternate day as the threshold dose. So give the threshold dose daily for 5 to 7 days during an episode of intercurrent infection, and this intervention appears to reduce the risk of relapse. Another good thing that we can do is give them annual influenza viral vaccines. Every year you give, and also give the pneumococcal vaccine, and so that the infection risk is minimized and the relapse risk is also minimized. And I am going through the various drugs which are available. We have to brush through the dose and all. And the Levamisole is given by after inducing remission. Most of these molecules are not remission induction agents. They are only maintenance remission agents. So you induce remission with steroid and start Levamisole, and then you have to continue Levamisole for at least 1 to 2 years. And we have to continue prednisolone, slowly taper the prednisolone and maintain at a low dose prednisolone for 6 or more months and try to come off steroid. Leukopenia is a difficult problem that granulocytosis can occur. So we have to monitor the total count every 12 to 16 weeks. Cyclophosphamide is another molecule, and cyclophosphamide is actually can be given as an oral molecule or can be given as IV pulses every monthly for 6 doses and taper the steroid during that point of time and stop the steroid for over a period of 2 to 3 months. And this molecule also needs a monitoring of total count And when you are using IV molecules, IV cyclophosphamide, there is risk of hemorrhagic cystitis. Whereas orally, when you use, the problems of leukopenia and gonadal toxicity is there if you are using the more than the ceiling dose. So you have to take the informed consent before we give the cyclophosphamide. And then mycophenolate Mofetil is also a good molecule in FRNS and SDNS. It is an attractive alternative to CNI as the renal toxicity is not there. But the problem is, again, we can maintain remission, but MMF dependence we will see, and the lack of renal toxicity, the hemodynamically mediated kidney injury, and metabolic toxicity are the good points regarding mycophenolate Mofetil, but the count needs to be monitored. The GI discomfort, abdominal pain, diarrhea can be there sometimes, which actually sometimes warrant the withdrawal of the drug. Cyclosporin and Tacrolimus are again effective and relatively safe, and the dose is 4 to 5 milligram per kilogram per day, which is given for 2 years. But most often what happens is we will be continuing cyclosporin or tacrolimus for a long, long while, because the moment we start withdrawing these molecules, the child may go into a relapse. And another disadvantage is the initial response to cyclosporin may not be obtained in subsequent introduction of the molecule if you stop it in between. And the trough levels in the first 6 months is 80 to 100, and then subsequently you can come down on the dose to maintain remission, and the doses and the level is 60 to 80. Nephrotoxicity is a problem, and the renal biopsy is to be done after 18 to 24 months. Tacrolimus is similar efficacy and similar mechanism as cyclosporin. Trough levels is 5 to 8 nanogram. The cosmetic adverse effects, the hypertrichosis and the gum hypertrophy is less, but the nephrotoxicity is almost the same. Tremor and risk of hyperglycemia is also there. The Rituximab is the molecule that has come of late, and now lot of people are using, lot of studies are coming out. This molecule is good in maintaining remission, but the problem is it is a molecule that can cause anaphylaxis, risk of infections, and progressive multifocal leukoencephalopathy. So what are the challenges? The risk versus benefit of the non-corticosteroid therapy. Are we introducing the problem of the dependence of steroid to dependence of these molecules? Can we stop the treatment? What is the long-term risk? What will happen to these children in long run? Will they become normal by adulthood? Is there any risk of progression to ESRD? 60 to 70% of FRNS and SDNS response, but the real therapeutic challenge is dwindling between relapses and the menace of side effects of drugs, and high chance of relapsing into adulthood. There is a problem of late steroid resistance coming up in 20 to 30% of children, and this is difficult, and the drug side effects are more, and there is challenge of severe disease and progression to ESRD. So to recapitulate, low dose dependence, childhood difficulties, maintained on steroids alone, and they usually outgrow the disease. High dose dependence, requirement of alkylating agents, CNI and all, difficult course, drug side effects, cataract, obesity, impaired growth, delayed puberty, overall altered mental makeup. And relapse rate after 18 years is 27 to 42% in this group, and late steroid resistance is associated with the risk of progression to ESRD. And the risk of adulthood disease is younger age of onset, high number of childhood relapses, use of CNI and alkylating agents. Thank you.
Thank you so much, Dr. Susan, for that excellent presentation. Since we are talking about, we're going to go on to steroid-resistant nephrotic syndrome. Before we do that, we'd like to introduce our nephropathologist, Dr. Mahesha, who is from Bangalore. Mahesha, please share your slides.
Can you
He's
speak
going to
louder?
talk on what is the role of the nephropathologist.
Can you
So he's
speak louder? Not very clear.
Okay, we're now going to talk. Now a nephropathologist talking. It's Dr. Mahesha. He's from Bangalore. He's a clinical nephropathologist and the head of the Department of Pathology and Laboratory Medicine, Manipal Hospital. His field of expertise is nephropathology and renal transplant pathology. So he's established the referral center of excellence at the renal transplant pathology unit at the Manipal Hospital in Bangalore, and he's co-authored many chapters. The reviewer of the board, board member of the Pathology and Nephrology journals, and is an executive member of the Indian Society of Renal and Transplant Pathology Society. So I welcome Dr. Mahesha, a young nephropathologist, to talk to us about the role of the nepropathologist in nephrotic syndrome. Over to you, Mahesh.
Good evening, everyone. I'm Dr. Mahesh here. Thanks to IAP Kerala for giving me this opportunity. I'll be going through the role of as a renal pathologist, how one can help in the assessment of pediatric nephrotic syndrome. We have heard in the previous talk that how does a nephrotic syndrome is defined and what is the definition of a relapse and the resistance, when do we call it as a resistance, and the steroid dependency. So as a renal pathologist, I'll just quickly go through the biopsy protocol that we follow, and has to be uniform in across all the assessment of these renal biopsies. This is how renal core, when we take biopsy and they are divided. So if there are two cores, 2/3 of it is given for the light microscopy, as indicated here as LM, and the IF stands for the immunofluorescence. So from both the tissues, there has to be division for immunofluorescence. And at the tip of the each of these core, a small 2 millimeter of the tissue can be chipped off and subjected to electron microscopy. And these are the fixatives that are to be followed for immunofluorescence. It's the Michel's transport media. It just holds on to the immunogenicity of the immunofluorescence. In the Are you able to see this screen? Hello? Yeah. So in the light microscopy, the sections which are to be cut is that of 3 microns, and the various special stains that we use is the PA stain as given in this picture, and the meson trichrome and the silver stain. Each of the tissue has to be cut in multiple step serial sections. The recommended is it has to be more than 24 or 26, although the different labs even go up to 36 step serial sections. Like as you see in this, on each of the slide, there are 4 to 5 step serial sections, and alternate slides are stained with different stains like the HND, PAs, meson trichrome, and the silver stain, and subsequently the next set of stains. So the adequacy of a biopsy is considered as normal when there are more number of gloms. So there is no upper limit to how many gloms could be sampled, but in terms of adequacy for the interpretation of exclusion of the focal lesions, as it may be like a FSGS or a thrombotic microangiopathy, which can be very subtle and focal in distribution. So to have a adequacy in the given sample, if we have 25 gloms in the core, then the possibility of missing the focal lesions is up to 5%. So any number of gloms decrease in this is reflected here as a percentage of missing the lesions that we are having in the clinical diagnosis. So like say if there is a nephrotic syndrome in a second decade, and if we have only 10 gloms, then the chance of missing FSGS goes up to 35%. So that is a implied value of having more number of gloms in ruling out the lesions. And also the second parameter is the location of the glomeruli. So here in the below, there is this part is a cortex and this one is a medulla. So anything is in between the interface of the cortex and the medulla, these are called as the juxtamedullary glomeruli, and this set of gloms are more prone for segmental sclerosis than the gloms which are located in the superficial zone. So having this in the core makes more value, adds more value to the assessment in a given case. So the number of step serial sections, I have talked about this earlier. So as this talk is about the podocytopathy, so we'll quickly go through the normal structures, the capillary wall and the mesangium, which makes this glomerular tufts. So in a given glomerulus, there could be around 5 to 8 glomerular tuft when we see it at a two-dimensional section. So, each of this capillary wall, as given here in this pictorial diagram, are lined by the capillary wall, and on the outer side is the podocyte, which sends their tentacles or the foot process, which sits on this capillary wall, and on the inner side is the endothelium, which has these fenestrations. So, and all these capillary walls are held together by the mesangium, which has the mesangial cells as well as the matrix material in between these mesangial cells. At the ultrastructural level, we can see that the podocytes or the visceral epithelial layers sitting on this capillary walls, and the endothelial cell lining this capillary wall. So at the ultrastructure, here are the structures. Like this is the basal membrane, which has 3 layers: the lamina densa or the center, and the externa and interna, which reflects of this basement membrane, and on the inner side the endothelium, which are gapped up, which are called as fenestrations, and on the other side the foot processes here are sitting on the basal membrane, which has this slit diaphragm. So these things are very important in the filtration of the protein or anything which filters out by this glomerulus. So in the assessment of these podocytes, the podocytes can be injured in 4 different types. So one is in terms of reorganization of the foot process architecture because of the cytoskeletal changes in the podocytes, which in the histology reflects no change in the number of these podocytes, and hence in the light microscopy it looks as if it's from a normal kidney. Whereas the second is that of a mechanism which includes this apoptotic mechanism, and there is a cell death with decrease in the podocyte number, and in the microscopy we get to see this segmental sclerosis. It may involve a part of the segment of glomerulus, or it can even span out in different gloms. The third one is that of a developmental arrest, where the solidification of the glomerular tuft is seen with relatively increased number of podocytes to a certain extent, and this is entitled as a diffuse mesangial sclerosis. The fourth one is that of a collapsing glomerulopathy. So as I'll just go through these different biopsies, how do we see the histology as well as the ultrastructure. This is about a child aged 13 years with nephrotic syndrome. As a presentation, he had 4+ of albumin with a protein leak of almost 3.5 grams per day, and a normal renal function. So in the renal histology, so as mentioned here, this core had 15 gloms, and these are the vascular pole and the tubular pole of in this patient. On the left side is the PA stain, and on the right side is the silver. As we see here, the normal structures are maintained: the mesangial area as well as the capillary walls, and the architecture of the entire glomerular tufts in this glomerulus is absolutely normal. Same is reflected here in the silver stain. In the silver stain, the capillary walls, where it is cut at the perpendicular, they are normal in thickness, whereas some are at the tangential level. There is no proliferation or increase in the mesangial cells in both of these pictures. So as in the next step, the immunofluorescence, as you see, these are the glomeruli which are highlighted in the circles, and the rest of the tubules serve as an internal control. The glomerular tufts are absolutely negative for this immunoglobulin for IgG as well as IgA and IgM. So in this case, the histology is normal in the light microscopy, as well as the immunofluorescence doesn't show any lighting up with any of the immunoglobulins or the complements. So as the same as highlighted here. So all these are negative in this panel. And in the in the ultrastructure, as compared to the normal on the right top, you see the striking difference in the arrangement of these podocytes, where in the normal they are foot processes which are alternated by these gaps or the slit diaphragms, whereas here, if you see that there is complete effacement across this basal membrane, which is covered by the effaced podocyte structure, the elements of the podocytes. And this happens in the minimal change disease. So in the ultrastructure, we need to assess across the capillaries and see how much is the effacement of these foot processes of the podocytes. So when it is more than 80%, then we call it as a primary process which is injurious to these podocytes. There are various other variants of the minimal change, like as you see in this case, a different case where he had a frequently relapsing nephrotic syndrome. And in the histology, there was subtle increase in the mesangial matrix. However, the mesangial cells were normal within the normal limits. And this is the same. In this section, there appears to be slight increase in the mesangial cells as well. In the silver stain, there's nothing added to what it is seen in the previous stains. And the immunofluorescence is the clincher in this, in terms of deposits of the fine granular material in the mesangial region. So this is limited to the mesangium. However, in the capillary walls, they are negative. So that was a case of C1q nephropathy, which is diagnosed by the immunofluorescence. And in certain cases, the IgM would be positive in the same mesangial region, and these cases are attributed as IgM nephropathy. So basically, these variants IgM nephropathy and C1q nephropathy are usually seen in cases of those who are steroid resistant, and the biopsy is done to rule out if there is any focal sclerosis or not. So whenever we see certain amount of mesangial cell proliferation, there will be a positive findings in the immunofluorescence in terms of these two entities. So we'll go to the next case, which is a sequelae of the first biopsy and then followed by second biopsy in this patient. This is a 16-year-old adolescent who had nephrotic syndrome along with hematuria, and the urine PCR was 4.3 with a low serum albumin and normal renal function. So in this low magnification of this PA stained slide, we see that there are 3 gloms, but at this scanner level itself, there appears to be slight increase in the mesangial region. So we'll go into the depths of the abnormalities in this. So as we see here, the mesangial matrix as well as the mesangial cell proliferation is quite exuberant, with the capillary walls being patent all throughout without any endocapillary proliferation. So as you see here in these circles, it's only in the mesangial region, but the capillary walls are all patent without any presence of endocapillary proliferation, or there is any kind of a neutrophilic infiltrate. So since this patient had hematuria, that those negative findings will be of important. In the immunofluorescence, as the primary abnormality is in the mesangium, and this patient didn't have any findings of IgA nephropathy, and all the other panel of immunoglobulins and the complements kappa and lambda were negative. So this makes a diagnosis of diffuse mesangial hypercellularity, which is a variant of minimal change disease. So this kind of a histologic entity, the patients who have this entity are more of a steroid non-responsiveness initially, or with the frequent relapses in the subsequent period, compared to those who have classic minimal change on the histology. But on the long run, the prognosis remains the same as it is with that of a minimal change disease. It's only the relapses that are more important in this entity. So this patient was treated with steroids followed by resistance, and subsequently added with the cycloendoxone of 2 doses, and there was no reduction of proteinuria, and she had renal deterioration as well, which to some extent was improved. But at the gap of around 6 months, the clinician thought there is a need for biopsy to look for what is the cause for renal deterioration. And in these glomeruli here, they appear to be slightly enlarged for a 16-year-old girl, as well as the tubules showing significant attenuation of the lining epithelium. So in this glom, which is highlighted here, has almost a segmental sclerosis with only few of the tufts being spared. Otherwise, more than 60% or 70% of this glomerular tuft is all sclerosed. And in another glomerulus also, there is a segmental sclerosis which is occupying in this part of the region. And this glomerulus has slightly increased mesangial matrix. So here again, the immunofluorescence in this case were negative for all the immunoglobulins, except for this trapping of the IgM, which is kind of a larger molecule in the area where the sclerosis is seen. So this kind of the immunofluorescence score also makes a difference, because if we see normal histology at the light microscopy, and if we have trapping, then the segmental sclerosis is more like that of a representing FSGS. So in this ultrastructure, when we see the cases of FSGS, these are the findings which clinch the diagnosis. So the villus transformation of podocytes, basically the tentacles of the podocytes, which are thinned out very narrowly, and the effacement is also partial. So there are few slit diaphragms left here, entitling this as a focal sclerosis. So this is how we go about the classification of focal segmental glomerular sclerosis. So if we have a collapsing variant, then we call it as collapsing. Further to that, if we follow this hierarchy to come to a last diagnosis of NOS, nothing not otherwise specified. So the surrogate markers in the renal histology, like if we have lesser number of gloms and we still don't have the segmental sclerosis, but the presence of tubular atrophy and the interstitial fibrosis indicates that there is a focal sclerosis in the vicinity, and also the glomerulomegaly can be a subtle indicator that in the due course the FSGS may be manifested. Move on to the third scenario. This is about nephrotic syndrome in the first year of life, and the histology was along with the deterioration of the renal function. In the histology, there were striking presence of these uromodeline casts which are dilating the tubules, but at the glomerular compartment, they all seem to be sclerotic all throughout the tufts, whereas the Bowman space is completely spared out, unlike in an obsolete glom. So as you see here, in all of these marked ones, the Bowman space is present, and there is a crowning of podocytes in these sclerosed tuft, as you see in the mesons trichome. apart from the glomerular compartment, there is significant amount of interstitial fibrosis.
Yeah.
And this points to the diagnosis of diffuse mesangial sclerosis, and there are usually these patients are having either a syndromic presentation of DMS in terms of Dennis-Drash syndrome, or the Fraser syndrome, or Pearson syndrome, indicating which of these genetic mutation is present in a given case. So to end my presentation, this is last slide on the patients who have been given the CNI therapy and they are biopsied, just to look out for if there is any effect of the CNI in terms of this striped fibrosis. As you see here, the zonation of these fibrosis. So the role of our renal pathology assessment is in terms of diagnosis of these podocytopathies or the variants, which helps in the initial management for the clinician to counsel the patient attendants that there is a possibility of relapse or the resistance, and the subsequent follow-up is very much mandatory. And also at the ultrastructural level to delineate whether the given podocytopathy is a primary or a secondary to any other obesity related, to name few examples. And of course to prognosticate in terms of chronicity of the in the glomerular or the tubular interstitial chronicity. And perfect clinicopathology discussion would help in managing of these patients. So with that, I give on to the next speaker.
Thank you, Dr. Mahesh. It was excellent. We needed somebody to tell us about all the. I think the PGs would have enjoyed seeing all your slides. It was excellent. Now we go on to Dr. Anil Vasudevan, who will share your slides. Please, Anil. It was amazing. I've gone through renal pathology for many years with Dr. Anand Tate, and I've enjoyed seeing all these electron microscopic pictures. It's excellent. Thank you so much for that presentation. We're going to go on to steroid-resistant nephrotic syndrome in children, and this is another difficult area of nephrotic syndrome, and it will be dealt with by Dr. Anil Vasudevan. He is the professor and head of Department of Pediatric Nephrology at St. John's Medical College Hospital. Areas of interest are genetics in renal disease, molecular basis of nephrotic syndrome, and as you will hear more about genetic testing in steroid-resistant nephrotic syndrome when he goes along with his presentation. His interest is also in acute kidney injury and low-cost devices. A lot of recognitions. I don't think I'll go through all of them, but he's somebody that we have handpicked for this particular topic. Over to you, Dr. Anil Vasudevan.
Thank you, Jason, sir, for your kind invite. Thank you, IAP Kochi and Anil Matthew, for putting in touch with this interesting webinar series. You have heard till now a totally different dimension of nephrotic syndrome, and nephrotic syndrome is because of disturbance of this beautiful cell, which is an electron microscopic picture of an podocyte. As you can see, the cell body and the foot process wrapping around the capillaries, which form the filtration barrier. So how some children which are affected by, where the podocyte are affected, have steroid sensitive, whereas they become resistant. We are having a better understanding of it now. And in the next 10 minutes, I will be talking about what is actually SRNS and how do you approach their evaluation, and a brief overview of the treatment of SRNS and the outcome, because it's very important to know the outcome, because intensified immunosuppression is one of the key preventive way of managing these children from going into renal failure. And I will be also touching upon the recent guideline released last month by the International Pediatric Nephrology Association. So let's begin with the case. This is a young child who presented with edema. On examination has edema, no other systemic features. The investigations confirmed nephrotic syndrome. Now, hearing all these talks, you have initiated prednisolone at 25 milligram per day, that is 2 milligram per kg. And now you have followed up this child in your clinic after 4 weeks, where you find that edema has disappeared, child is mildly Cushingoid, and urine albumin is 2+. What's your impression, and how are you going to further approach this child? So the question here is 2+ indicative of remission, or not. So the definition of SRNS, we follow the Indian Society of Pediatric Nephrology guidelines, which says that absence of remission after 4 weeks of therapy with 2 milligram per kg, that is urine albumin nil or trace. If that does not happen, then it's steroid resistant nephrotic syndrome. This is in contrast with the KidGO guidelines, where you say that you assess response after 4 weeks of daily and 4 weeks of alternate day treatment with prednisolone. And the recent guidelines by IPNA took the middle path. They said wait for 6 weeks of steroid therapy and then assess remission and then define it as SRNS or not. Very soon we are releasing our new guidelines, and we are going to follow the IPNA guidelines of absence of complete remission at 6 weeks to be taken as steroid resistant nephrotic syndrome. And this definition applies whether the child is resistant in the first episode itself or develops resistance after a brief or a prolonged course of steroid sensitive nephrotic syndrome. Since SRNS has a different trajectory, it's very important to confirm this. So we need to rule out pseudo resistance, that is, the dosing has been correct, the compliance has been correct, especially with syrup where the two strength of formulations available. We have to ensure that the right dose is gone. There are no infections which can trigger a relapse, and also that child is not on any other medications that can interfere with steroid efficacy. For example, with rifampicin, with seizure medications like phenytoin. So when we look at SRNS, we identify two groups of children. One, where they have late steroid resistance or initial resistance, they have variable response to immunotherapy, and they have a high recurrence after transplant. And they are supposed to be because of circulating factors which we have no idea about. The second group of children are those who are always initial steroid resistant. They have a very young age of onset. They have no response to any form of immunosuppression. They have a low risk of recurrence, and usually sometimes we may find family history of steroid resistance in the family. And these children are the group of children who may have probably an underlying genetic cause. So how do we work up these children? SRNS is a very complex disease with a different etiology. The management plan is very complex. They're prone for many adverse effects, including those of medications, high chance of going into end-stage renal disease, and also requiring transplant. So these children need to be referred to a physician who is experienced in managing children with SRNS, preferably a pediatric nephrologist, and subsequently the follow-ups can be co-managed with pediatricians. In the investigations, I want to highlight three things. That is, one is that a good clinical examination. Why? To uncover a syndromic cause of steroid-resistant nephrotic syndrome, so that you can order a genetic testing. And second is a secondary cause like lupus or a HIV related, where you can order an appropriate investigations. Second thing is, along with the urine analysis, you have to do a quantification of the urine protein, either by a spot protein creatinine ratio or a 24-hour urine estimation in older children. But both of them are fine while evaluating children with SRNS. And why do you need to do this? Because it's important to assess response to any further immunosuppression as complete, partial, or no response. Unlike steroid sensitive, where you expect complete remission with any form of immunosuppressive therapy, in steroid resistant, even a partial remission can be a reasonable outcome if the child does not go into a complete remission. And it's very important to quantitate the proteinuria. Second thing is, you need to do a serum creatinine because one is the nature of disease. Second, it could many of the drugs can affect kidney function. So it is important to have a baseline creatinine and estimate the GFR using a Schwartz formula. The third tool that is used now in the test, in the evaluation is steroid in SRNS, is genetic testing, which I will come to that a little later. So in an examination, as I said, apart from evaluating for secondary causes, looking at the eye, genitals, head circumference, skeletal structure, developmental assessment is important to identify a syndromic cause, because these have genetic and do not respond to immunosuppression. For example, the child with a microcephaly could be a Galloway-Mott syndrome. If there's an ambiguous genitalia, it could be a Dennis-Ras syndrome. If they have a child who has developmental delay, seizures, or hearing defect, it could be a mitochondrial pathway associated SRNS. If the child has microchoria, it could be a Pearson syndrome. If they have characteristic nail changes, it could be a nail patella syndrome. So a good clinical examination is very important in a child with SRNS. What about biopsy? We have heard Mahesh who gave us a wonderful overview of that. I just want to highlight that majority of the biopsies are FSGS, as we find in our series of 100 children with SRNS. The other thing why you do a biopsy is to rule out other causes of NS, which isn't exactly like a nephrotic syndrome. For example, lupus, IgA, and membranous nephropathy, and very rarely Alport syndrome. Now, as I said, one of the tool that has been used now in evaluation is genetic testing. And it started with congenital nephrotic syndrome when they discovered the NPHS1 gene to be affected in congenital nephrotic syndrome, and that was 30 years back. And after that, there have been more than 70 genes that has been identified in SRNS, and these 70 genes are responsible for steroid-resistant nephrotic syndrome in 1/3 of those SRNS. And this proportion increases in familial cases. It is not that all children with SRNS have a nephrotic as a mutation. It is especially those who present less than 1 year of age. As you can see, 2/3 of them have a genetic mutation, and the proportion of genetic mutation decreases as the age of onset becomes more older. For example, in adolescent, it contributes only to around 10%. And why do we do a genetic testing? Because this helps in individualizing treatment. That is, these children do not respond to immunosuppressant, so you can withhold immunosuppressant. It helps in prognostication. It helps, especially in a familial case, for antenatal diagnosis. And also, these children, if they get transplanted, they do not have recurrence of the disease. And also, since the genetic can be inherited, you can select the appropriate donor for renal transplant. Another utility of genetic testing is that it can uncover a phenocopy. That means a disease that mimics nephrotic syndrome, for example, Alport syndrome, or a dense disease which is a tubular disease but can present as a nephrotic syndrome. So as you can see, the genetic testing is very useful in SRNS, but whom do we test? Is it that all children with steroid-resistant nephrotic syndrome? Here again, we can identify those who needs genetic testing. So any children with age of onset of nephrotic syndrome less than 12 months, with a family history of SRNS, or has a syndromic nephrotic syndrome, or has diffuse mesangial sclerosis, as Mahesh explained in biopsy, or those children who are initial resistance to steroid and are also tacrolimus cyclosporin resistant. These group of children need genetic testing. If the steroid resistance is secondary, that is after a course of steroid sensitivity, then we do not recommend genetic testing. So what kind of a genetic testing do you do? There are two methods, as you know, broadly: Sanger sequencing, which looks at few genes, and NGS, that is the current way of testing genes in SRNS. And we recommend NGS-based testing, except in syndromic or familial onset, where you have already identified a gene. As you can see in our experience, when we look at 1 or 2 genes, we don't pick up many, like hardly 5% of the 100 children. But if you do an NGS panel of just 17 genes, the yield is much higher, and that's why we recommend a next generation sequencing based genetic testing. So we're coming back to this case. Now you have re-examined the child. There are no syndromic features. You have quantitated the protein. You have worked up for a secondary causes, which is negative. You have done a biopsy, which is FSGS. Now, what do you think should be the way to go? What treatment can you offer to this child? So when you look at the therapeutic options, unlike steroid sensitive, it is very limited. It's basically the CNI and cyclophosphamide. Mycophenolate and Rituximab is usually used in CNI resistant, but is not as effective as in steroid sensitive. A decade back, what is called a pulse steroid therapy was very popular in managing this group of children, but this has practically been discontinued because of a high prevalence of complications, especially life-threatening infections and irreversible steroid toxicity. So as you can see, CNI is the choice for the management of SRNS. And with CNI, you are able to achieve somewhere in 2/3 complete or partial remission. But unlike steroids and steroid sensitive, these CNI take time, so you have to give it some time. So a median time to complete or partial remission is anywhere between 2 and 3 months. In steroid resistant, after 4 weeks, you can diagnose. But when you give CNI and assess for response, you call it CNI resistance only after 6 months of treatment, and you have demonstrated no response. Once the child goes into remission with CNI, as you can see here in approximately 2/3, how long do you continue? There are no consensus on the duration of therapy. The Indian guidelines suggest 2 to 3 years of CNI therapy, whereas the recent IPNA guidelines says at least 1 to 2 years, because prolonged courses of CNI are associated with its own risk of especially nephrotoxicity. Even after 2 years, when you discontinue, 70% of them may relapse, but they may respond to steroids. So relapses on CNI in a child with steroid resistant, you could still treat with steroids, and a small proportion becomes steroid responsive after being treated with CNI. What about those children of steroid resistant who have a genetic mutation? Here, it is immunosuppressive therapy is not advised. So it is better to, because the risks are too high, especially of nephrotoxicity, you prefer to manage them with just supportive care. Now, there are two forms of CNI, cyclosporin or tacrolimus. So tacrolimus is preferred because of lesser, I'll come to that later. Cyclosporin is available in syrup, whereas tacrolimus is not. So you prefer cyclosporin in young children and also in children who have glucose intolerance or seizure disorder, because tacrolimus is contraindicated. An advantage of using CNI is that you can titrate the dose by measuring the drug trough level. Now, coming to the toxicity, they are potent drug, but also at the same time very toxic. So these are the toxicity that we need to screen for. And why we do not prefer cyclosporin is because of the cosmetic side effect of hirsutism and gum hyperplasia. So these children on CNI needs to be monitored every 3 monthly, clinical examination, blood pressure, and a set of labs, including renal functions and LFT. Another important point that you have to remember is that many of these CNI can interact with other drugs. So if a child with URI comes, be careful not to prescribe erythromycin or clarithromycin because it increases the level of cyclosporin. Be careful while you are prescribing antifungal because again it can potentiate nephrotoxicity. And children on anti-seizure medications like phenytoin, antitubercular like rifampicin needs a higher dosage of these drugs because these drugs are faster metabolized when you use these drugs. Same precaution is advised. We have to be cautious when you're using NSAIDs in these group of children because they can potentiate nephrotoxicity. What about cyclophosphamide? It was popular, but again now it is not because it is far less efficacious as compared to cyclosporin. Only 1/3 of the children have some form of a response, and late resistance do better. Unlike in steroid sensitive, there is no role for oral cyclophosphamide. And IPNA and the recent guidelines says that you can use IV cyclophosphamide if the family is not affording or has adverse effects to calciurinate inhibitors. An important component apart from immunosuppressive therapy is the use of AC inhibitors. All children with SRNS should be on an AC inhibitor. As you can see in this RCT from AIMS Delhi that showed that 52% had a significant reduction of proteinuria with usage of an appropriate dose of enalapril. So dosing is very important to achieve the antiproteinuric effect. But we need to be aware of the side effects of acute kidney injury, hyperkalemia, and we need to withhold these medications in case of dehydration, diarrhea, and vomiting to prevent AKI. Along with this, we need to initiate a host of supportive measures because they are proteinuric, they leak a lot of binding proteins, they're at risk of vitamin D deficiency, thyroid, and iron deficiency. They need to be supplemented. The comorbidities like hypertension needs to be managed with antihypertensive, dyslipidemia usually with diet, and above 5 years with statin therapy. We also need to assess the growth and nutrition, which will be discussed in the subsequent talk. And these children, because of these potential toxicities and to assess the efficacy of therapy, needs to be followed up every 3 months, even if they are in sustained remission. I'm skipping this slide because of lack of time, but what I want to show is the final algorithm in an approach to management of SRNS. So if you have a child of SRNS, you first see whether it's syndromic, familial, or non-syndromic. If it is syndromic, you go for genetic setting. If it is non-syndromic and sporadic, you start as CNI. You assess the response after 3 to 6 months. If there is a complete or partial remission, then you continue the therapy. If there is no complete or partial remission, you order a genetic testing. If it is positive, you just stop immunosuppression, just put them on some supportive measures and counsel them about the progression to ESRD and needing the transplant in future. If they are in remission with CNI and then you continue it at least for 2 to 3 years. You can treat the relapses with steroids and also titrating the CNI dose by measuring the drug level. If they are CNI resistant and genetic negative, you could consider rituximab 2 doses or a combination of CNI MMF. One third of them may show a response to one of these two options. And if they are in remission, you continue CNI MMF for 2 years. If they don't, they are labeled as multi-drug resistant, steroid resistant nephrotic syndrome and are just put on supportive measures like in those who have genetic positive. So how do these children behave in future? It all depends on two things. One is treatment response, the other one is genetics. So if you have a complete or a partial response, as you can see here, most of them do well. But if you have no response to CNI or the other medications, then 50% of them end up in renal failure within 10 years of diagnosis. And what about those with a genetic cause? Even in them, as you can see here, only 1/4 of the children do not have end-stage renal disease. That means 75% of the children with a genetic diagnosis go into end-stage renal disease within 10 years of diagnosis, as opposed to a very few when they are non-genetic and they have responded to CNI. So clearly the prognosis is dependent on how well they do on calcineurin inhibitors and whether they have a genetic mutation or not. So what do you do with these children who go into ESRD? So it is transplant, which is the definitive treatment. Dialysis is usually used as a bridge. And in fact, SRNS is the second most common cause of transplant in children. And the response, the overall success rate is comparable with other renal disease in children. But there's two challenges that we need to overcome. One is recurrence of disease, which is seen in nearly 30 to 50% of them undergoing a transplant. And proteinuria is usually the first sign of recurrence. And the other one is vascular thrombosis, because they have a very viscous blood. And also these are small children who are getting transplanted. So in them, genetic testing helps in predicting recurrence. So who have a genetic positive, the recurrence is very rare, as opposed to those who do not have a genetic mutation leading to SRNS. And also genetic testing should be done in the donor in order to identify that they are not carrying especially the dominant gene variant. Then you need to exclude them as the donor. And the treatment of a recurrence is early institution of plasmapheresis and rituximab. So with this, I've given a brief overview, a quick review, and I would like to highlight that the Indian Society of Pediatric Nephrology is coming up with a revised guidelines probably in a couple of months from now. Thank you.
Thank you, Dr. Anil Vastavan, for making it difficult topic more difficult for all of us. It's really it's a new area with genetic testing and management of the steroid-resistant nephrotic syndrome. While we have gone to the heights of the nephrotic syndrome and its management, we'll now go on to the diet in nephrotic syndrome by Dr. Elizabeth. She's Dr. Elizabeth, can you share your slides, please? We are short of time, so we'll have to rush through some of the presentations, but we'd love to hear Dr. Elizabeth on nutrition, because she's an expert on in nutrition. He's going to talk on the diet management of nephrotic syndrome. Can you have your biodata slide, Dr. Elizabeth? She is, next slide, please. Dr. Elizabeth. The next slide, please. Yes.
My slide is not moving.
Oh my gosh. Can you just talk then, because you want me to share your slides? Yes.
Please do it.
Yeah. Then just remove your slides. Can you see the slides?
Yeah. Yes.
Okay. Yeah.
Thank you, Dr. Jason.
Yeah. You
Dr.
tell me to
Pramod,
change when.
IIP Kochi and IIP Kerala for this wonderful opportunity. So, being a pediatrician, my take would be on the growth of the child, whether it is nephrotic syndrome or not. So we have to capitalize on the balanced diet with a my food plate. The food plate should be complete, at least on a daily basis, with the 7 colors. So what are they? The first 4 colors, green, yellow, orange, red, represents vegetables and fruits, and it will supply all the micronutrients. And the 5th color, brown, will be the staple diet for whole grains and roots and tubers for carbs. And then the 5th is purple for protein. That is very important in nephrotic syndrome also. Then the 7th is the white, that is the milk and milk products for that is for calcium, phosphorus, and the fat soluble vitamins. By and large, carbs should supply 55 to 60%, and protein should be not less than 15%, and fat restrict to 25%. That is, saturated fat should be only 5%, and trans fat should be 0. What is trans fat? It is something which is solid at room temperature. For example, the vanaspati, the dalda, the animal fat, and the ghee also has got 4% of trans fat. And there should be enough fiber, 5 plus age in years, otherwise half your weight. If the child's weight is 10 kilo, 5 gram is what is required. We were so far thinking about only macronutrients and micronutrients. Now we are thinking about type 1 or functional nutrients, which when deficient will show specific deficiency signs. So what are they? That is iron, iodine, calcium, vitamin A, etc. And we can run a program and the child can store it up. Whereas when it comes to growth nutrients, that is type 2, it has to be there on a daily basis. That is nitrogen, essential amino acids, potassium, zinc, sodium, etc. So in a there are a lot of clinicians' dilemma when treating nephrotic syndrome, and we have heard that it is not one disease that we are dealing with. So first of all, we want to give moderate to liberal protein. So what is the effect of high protein on the kidneys? Salt restriction means how much salt, how much sodium, and how to adjust fluid when there is hypovolemia, when there is diuresis, oliguria, and fat restriction means only cholesterol or total fat. Then what about electrolytes, and how to go about in an obese child, because these children are on long-term steroids and they have good appetite and they may be obese. So by and large, the common practice is that we go for a moderate to high liberal protein. 1.5 gram per kg is moderate and 2.5 is liberal. And we have already said that 25% of the calorie can come from fat, and physical activity should be promoted. And any child who is on prolonged steroids more than 3 months, or if you are planning to give it for more than 3 months, it is better that you give calcium carbonate and vitamin D. And hyperlipidemia will be triggered when there is hypoalbuminemia, and most of them may respond and may come to normal when the child goes to remission. But in some cases, even dietary modification may not lead to a remission in that. And regarding salt, when there is edema and hypertension, there should be salt restriction. And similarly, fluid restriction, that is when there is mild edema, you can go for restricted fluid, maybe 2/3 of the main dose. When there is moderate edema, we can go for insensible loss plus previous day's output. When there is severe edema, the child should be on a negative balance, give only insensible loss. For that matter, we must understand what is underfill nephrotic syndrome and overfill nephrotic syndrome. And in underfill nephrotic syndrome, it is the simplest model: hypoalbuminemia, decreased oncotic pressure, and hypovolemia. And all the fluid is in the extravascular compartment. And we can give we can manage this child in an easy way. Maybe we can give little albumin diuretics, and we can manage. Whereas the overfill child, in addition to this, there is intrinsic resistance of the kidney to the atrial natriuretic peptide, and also activation of the epithelial sodium channels. So this child is hypervolemic child. In hypovolemia, there will be dry mucous membrane, hypotension, then hemoconcentration, etc. And we may have to give boluses of normal saline followed by albumin and diuresis. And we may have to manage the fluid balance in that way. Whereas in hypervolemia, there is overfill. Giving albumin may suddenly increase oncotic pressure, and hypervolemia may get aggravated, but simple fluid restriction, salt restriction, and diuretics may help in that child. That takes us to the what is maintenance fluid. We used to look at the holiday and cigar formula for a day, but now we look at the holiday and cigar estimate, that is 4 ml per kg per hour for the first 10 kg, 2 ml per kg per hour for the next 10 kg, then for the rest 1 ml per kg per hour. And the insensible loss is 400 ml per meter square. Roughly a 9 to 10-year-old child with 30 kilo will be 1 meter square. In a smaller child, it can be calculated as 30 ml per kg for a day in a newborn, 25 ml per kg for an infant, under 5, 20 ml, and older child 15 ml. And in diuretic phase, we may have to go for a liberal fluid. What about an obese child? Correct for the ideal weight, because his physiology is like that for his age only, not for his weight. The weight is mostly fat. So regarding protein, how liberal? And there are studies which show that high protein, even when the kidney function is normal, very high protein can lead to glomerular hyperfiltration and damage to the kidney. Similarly, and the opposite will happen in the low protein diet, but some recent studies could not substantiate this. And previously, which protein to select, we were looking at biological value, digestibility. Now we are concentrating more on the PDCAS, that is protein digestibility corrected amino acid score. Look at egg. It has got a PDCAS of 1, biological value of 100, and 1 egg will give 6 grams of protein, and there is no rate limiting amino acid. So that is the best, followed by milk protein. And look at soy protein. It has got a PDCAS of 1, but it has a rate limiting amino acid, methionine is deficient. So we have to strike the balance, moderate to liberal protein. It should be lean meat, well trimmed poultry, and egg white, and fish, beans, etc. And limit whole egg to 2 per week, because there is lot of cholesterol. Up to 250 milligram cholesterol is there in 1 egg yolk. And healthy oil like olive oil is recommended. And some mothers say they have great difficulty. It is very clumsy to remove the egg white. This is an easy method. Take a bottle and try to suck it out, and then transfer it to another container. And I said after egg white, milk is the best. So cheese, many mothers may be using, but processed cheese, frozen dinner, then canned meat, pickled vegetables, salted potato chips, popcorns, all have high sodium. And so the table salt and the container should be away from the child, and ketchups and soups and the chips, crackers, Cheetos, salted nuts, all have very high salt. We must go for fresh products and fresh seasonings rather than the commercially available ones. And we have to teach them about the food labels. See, sodium-free diet means less than 5 milligram per serving, and low sodium means 35 milligram sodium, and very low sodium. And this is what is in the low sodium, that is 140 milligram sodium per serving is what is given. And look at the nutrition facts on the label. Suppose we are selecting this for the child, 250 calories per serving, that is good. But see, the fat is contributing to 50% of the energy. We said it should be 25 to 30% only. And fat is 18%. Anything closer to 20 or more is not good. And there is trans fat 1.5 gram. And cholesterol is there. Sodium is 470. I said 140 milligram per serving is good. And dietary fiber is 0. And protein is 5 grams. So this product is not at all good for a child with nephrotic syndrome. So the general advice when we come to table salt, we can say it is sodium chloride. So 50-50, sodium may be 50, but in fact it is only 40% sodium and 60% chloride, because there will be impurities like potassium chloride. And 90% of the sodium that we take comes from sodium chloride and the rest from soda bicarb. And sea salt and rock salt has more trace minerals, so total sodium may be less. And sodium into 2.5 will give you the salt in grams. So 140 milligram of sodium per serving into 5 meals. That means 700 milligram. That into 2.5 means it is 750 milligram of salt. That is less than 2 gram of salt is what is given. And my experience is that imposing and relaxing salt restriction is equal to losing a battle. So when the child is having frequent relapses or is steroid dependent or there is hypertension, it is better to go for a no added salt policy till we declare that is cured. And we said 2 whole eggs per day, moderate to liberal protein. If protein is restricted, the child will get into malnutrition. Now look at a 30 kg child on a 2000 kilocalorie diet. And I said no less than 15% energy should come from protein. That is 300 kilocalories should be coming from protein. To get 300 kilocalories from protein, 1 gram will give 4 calories. So 75 gram protein will have to be given. That means it will work to 2.5 gram per kg, which is a liberal protein. And as far as possible, avoid restaurant and takeaway items, and packaged food with long shelf life will have trans fat, because otherwise the item will get stale. And unlike calcium, there is no need to supplement potassium, because potassium is abundant in all protein-rich food, and concurrent use of phosphorus is abundant. So there is no need to give phosphorus. Calcium carbonate is what we give. And when phosphorus is high, calcium absorption will be less. And hyperphosphatemia is a complication in a child with CKD. And last but not the least, nutrition counseling is very important. Otherwise, if you fail to give them nutrition counseling, they will get advice from the senior patient or bystanders who are there. And that child may be having nephritis or nephritic type of nephrotic syndrome, and they may give the advice that you restrict protein, you restrict salt, you restrict water, you don't give fruits, and give liberal fat and carbs. But actually, this nephrotic syndrome child needs conditional restriction of salt, water, and sometimes it has to be liberal in polyuric phase, and fat has to be restricted, and protein has to be moderate to liberal, and fruits can be given. And the only common advice is that carbs can be liberal. So that it is a great responsibility for the treating doctor. So the take-home message is that we have to strike the balance in salt, fat, cholesterol, protein, and fluid. And it is not an easy game, because it is not a one disease. So we have to get it should be a teamwork and get the help of the nephrologist and the dietitian in this. Thank you.
Elizabeth. Am I muted?
Sir,
We can hear you. We can hear you.
Can hear
No
me?
problem. Yeah, we can hear.
Are you seeing the slide?
Yes, yes.
I can't move this. Yeah. Okay. So I'll rush through infections in nephrotic syndrome because there's not much time. We've gone through quite a bit, and we are short if time is there. So the nephrotic syndrome, you know that there is an immune regulation, dysregulation in the etiopathosis of nephrotic syndrome. And there are a lot of factors that causes immunosuppression in children with nephrotic syndrome. There is complement system disruption. There's a decreased depressed cell-mediated immunity. There is decreased humoral immunity, and the hyperlipidemia and the serum factors and increased T cell suppressor cell activity reduces the T cell function. There's less blast formation, transmission of the lymphocytes, and the edema, the sodium and potassium pumps are is a potential re-entry point for microorganisms in the renal tubule, and there is splenic dysfunction, decreased splenic function, which increases susceptibility to encapsulated microorganisms, and of course the treatment of causes immunosuppression. So there are so many factors which causes an increased risk for infection, and this is the factors 1 and B, which are required for activation of the complement system, and that is reduced, and therefore the chance of severe infections are there in children with the efficacy of vaccine also is suspect because of this immune suppression. And as we know, C3 is what's required, is a strong opsonin for the microorganism. That system is not functioning well. But over the years, there's been a definite decline in the infections in nephrotic syndrome, probably because of the standard of living, there's immunization that is coming, ability of good diagnostics and antibiotics, and early diagnosis and treatment of improved pediatrician awareness, and the updated availability of recommendations. I've seen so many recommendations coming up on a regular basis, and revisions are done depending on the response, and therefore the revision of from when you go on from sensitive to dependent to resistant. So there's a treatment schedules are there which help to reduce the severity of hypoalbuminemia and generalized NSACA, and therefore the infections have definitely come down over the years. And what are the risk factors for infections? Frequent relapses, and when they are on prolonged steroid therapy and immunosuppressants, there's hypogammaglobulinemia of less than 1.5 grams albumin, the severe NSACA, massive cyclophosphamide can cause cellulitis, unimmunized child. So these are the factors which will cause chances for infection. So you need a high index of suspicion. The family should be counseled along with that of the disease progression and diet to told what are the infections that could occur over time, and warning signs of infections must be told to these parents. The main infections nowadays is cellulitis, so general NSACA, so scrotal cellulitis, URI, maybe viral precipitates in relapses, and sometimes UTI. You don't see the spontaneous bacterial enteroperitonitis and the pneumonia and septicemia that you used to see earlier because of the factors that we mentioned. So remember that immunosuppression masks these clinical presentations. So you need to know what the presentations could be in these children who are slightly immunocompromised, and the geographical pattern of infectious disease changes in India. In Kerala, for instance, where the health conditions are very good and immunization coverage is better, you have a different infections in nephrotic syndrome than in other parts of the country. Now, as Dr. Susan has already mentioned, that when you get an infection, you can wait for a few. If it's a mild infection and it's not a complete relapse, sometimes you wait for the infection to subside, and rarely spontaneous remission of the nephrotic syndrome could occur. If remission, if you go into a relapse, then the treatment is, as Dr. Susan already mentioned, you give it for daily steroids until 3 days of no proteinuria, and then go on to alternative steroids for the next 4 weeks. Relapses is usually to viral URI, and when the steroid-dependent syndromes on alternative steroid, short course of daily steroid has been found to be useful in preventing a relapse. So when the child is on alternate steroids, you get a viral URI, you can give 5 days of daily prednisolone, and that sometimes prevents a relapse. And 85% of relapses are prevented in this particular study. Tuberculosis is something that we need to know that prednisone, when they're on high dose prednisone 4 weeks and on immunosuppressants, there's a risk of mycobacterial tuberculosis, and progression to TB is very high. So every child must have a Mantoux test done before he's starting and an X-ray test prior to starting. And if there is a response is poor or there is a refractory to the treatment, you must consider tuberculosis as a possible cause for that. And there you have to do a whole workup, IGRA, gene expert, biopsy, and cultures, because you must rule out the possibility of tuberculosis being the cause. Because if there is tuberculosis that is occurred due to the treatment, then appropriate ATT would help remission in these children with idiopathic nephrotic syndrome. You must realize that false positive Mantoux occurs when high dose steroids are given for more than a month. So when you're starting steroids, if you give Mantoux, usually it does not affect the Mantoux. It does not cause a false negative Mantoux. Detection with IGRA is slightly better, but that's not really usually done. And patients with nephrotic syndrome who are Mantoux or IGRA positive, but there's no microscopical diagnosis of tuberculosis, should receive a prophylaxis of INH for at least 6 months. Procalcitonin is useful in detecting whether bacterial sepsis. Cellulitis and abscesses do not significantly raise, and that is the most common infection that you see nowadays in nephrotic syndrome. It does not change the procalcitonin levels. And if you get very high levels of 10 nanograms per ml, probably it's a severe infection, and you can use it for monitoring, but it's only expensive, very expensive. Varicella is a very, very life-threatening disease in children with immunosuppressant therapy. So if you have nephrotic syndrome steroid exposed to chickenpox, immediately give a single dose of varicella zoster immunoglobulin. Within 96 hours of exposure, it will prevent or lessen the severity of disease. Because it's not easily available, you can try IVIG, but there's no data of its effectiveness. Once you develop the varicella, you must treat with acyclovir IV and later oral. The dose of prednisone, if you're on steroids and you get varicella, you must taper it to 0.5 milligram per kilogram per day or lower during the infection. These are the other things. The peritonitis, you know that you need Rituximab or Septria because it's S. pneumonia or as Streptococcus pyogenes or E. coli as the cause. Pneumonia, it is usually S. pneumonia again, H. influenza, Staphylococcus aureus. So amoxicillin is the first drug of choice. Otherwise, you must parenteral cefotaxime and Septria. Most often, you must use third disease cephalosporin in these children with severe infection. Cellulitis is usually Staphylococcus or cloxacillin with ceftriaxone would be the drug of choice for 7 to 10 days. You must think of fungal infections because sometimes you can get pulmonary infiltrates, which may be fungal, fever unresponsive to antibiotics, and sputum or urine showing septate hyphae. You must consider it to be a candida or aspergillus infection in children on steroids. So if it's skin and mucous membrane infection, you give fluconazole for 10 days. If it's systemic, you give amphotericin. Supplemental stress dose of steroid of hydrocortisone and prednisone should be given with these infections. For high dose, you must give stress doses, high dose of steroids for more than 2 weeks the past year. There's a risk of hypothalamo-pituitary adrenal axis suppression, and therefore, if you have a child who's had high dose steroids for more than 2 weeks in the past 1 year, you must consider corticosteroid supplementation as parenteral hydrocortisone after checking your cortisol levels for the duration of the stress. So with every infection that occurs while not on steroids, for those on alternate steroids, appropriate antibiotics with a stress dose of 0.0 milligram per kilogram as a single dose for 5 days may be advised. You must remember that if there's recurrent infections, you must think by primary immunodeficiency. There are about 7 or 8 conditions. We've seen IPEX, we've seen STIM, combined immunodeficiency, the CVID. These are all things that you must consider. If it is recurrent infection, Omen syndrome, these are all should be considered, and a genetic testing would, along with finding out what, like for instance, Dr. Anil Vasavan said, you must think of also genetic testing might pick up a PID, which may be cause for the recurrent infections. Immunizations, you must know that regular immunization should be considered. There are some studies that hepatitis B, measles, MMR, and meningococcal vaccine could rarely precipitate relapse. So live vaccines contraindicated that when you're on steroid-sparing or immunosuppressive agents. Immunize household contacts, absolutely essential to minimize the risk of infection to the compromised child. And if it's person, the contact has gastroenteritis, urinary or respiratory secretions of the vaccinated contacts, at least 3 to 6 weeks after vaccination, you must be careful with that contact. Following the close contact of varicella infection is very important. As we already said, you must give varicella immunoglobulin or whatever we have already mentioned. Live vaccines should be given only if the child is off cytotoxic drugs like cyclophosphamide and Glomerular for more than 3 months and off other immunosuppressive agents for more than 1 month. This is a chart which all of you will know about how you treat, you'd give vaccines for the various immunosuppressants that these children get. Pneumococcal vaccine, 2 to 8-year-olds, if they've completed their immunization with PCV13 in infancy and at 1 year, at 1.5 years of age, you give only 1 dose of polysaccharide vaccine. If it's unimmunized, no pneumococcal vaccine earlier, you give a priming dose of PCV13 and follow it up with 8 weeks later with a polysaccharide vaccine. Unimmunized child more than 5 years, you give the same and you add polysaccharide vaccines every 5 years afterwards if the risk of recurrence of nephrotic syndrome is persisting. Those vaccinated with polysaccharide vaccine, you should receive a single dose of Prevnar or PCV13 or PCV10 8 weeks after the last polysaccharide vaccine that the child is gone, especially in frequent relapses. Otherwise, if there is a risk of relapses are not so frequent, then the dose of PCV13 should be 1 year after the last dose of the polysaccharide vaccine. There is doubts of whether these vaccines are useful in nephrotic syndrome and whether it really prevents disease, but GMTs have shown that you get very good response for all strains. The only strain that doesn't get a good response is serotype 19 and 19A and F, which causes severe pneumococcal disease. The recent study has also shown that nephrotic syndrome, high-dose corticosteroids, if you respond very well to polysaccharide on the high dose, will respond to polysaccharide pneumococcal vaccine. And this is a major advantage of the strategy is that the patients who relapse during the tapering steroids already have an increased anti-pneumococcal antibodies at the time of relapse. So that is something that we must consider. And you must give a single dose of PCV13 8 weeks after this last dose of polysaccharide. Varicella vaccine, generally well tolerated and highly immunogenic in children with nephrotic syndrome. And so as soon as they're on low dose or alternately prednisone, you must give a varicella vaccine. Patients in remission and not immunocompromised should receive varicella vaccine, and more than 1 year 2 doses should be given at an interval of 4 weeks to 3 months. Vaccination, renal transplant, you know that when you get a child on renal transplant, you're always advised what immunization to give. If age-appropriate and inactivated vaccines are recommended as for the general population. Ensure that hepatitis A, pneumococcal influenza, and HIP standalone, if available, should be given to these children before the transplant. Hepatitis B vaccination, time is up, I know. Check the antibody levels and do accordingly. If transplant is planned, then if early vaccination, varicella and MMR can be done 4 weeks before the transplant. All household contacts must ensure that before transplant, all household contacts must be vaccinated for MMR and varicella 2 weeks prior to transplant. After transplant, no live vaccine, MMR vaccine for at least 2 years post-transplant and at least 1 year after discontinuing the immunosuppressive therapy. Vaccines, inactivated vaccines can be given 3 to 6 weeks after the renal transplant and intense immunosuppression. Inactivated influenza vaccine can be administered as early as 1 month after renal transplant to time it before the onset of flu season. So here we have it during monsoon. So the vaccination of influenza should be given before the influenza season, the flu season starts. And measure the hepatitis B titers on transplanted patients at least 3 months after completion of the vaccination and annually thereafter. Thank you so much. So we come to this end of this very exhaustive session. I think we will go on to the questions, the quiz first, before we go on to the questions. A lot of questions that have come on the chat box. So we'll have the quiz. Anil, can you, I'm stopping sharing. Anil, because we're short of time,
Yes,
we'll take the questions afterwards.
Yes, sir. Am I audible?
Yeah, sure.
Okay. Yeah, dear postgraduates, please answer to the questions in the chat box. You can number the question and then mention the right choice. So for each question, only one answer is correct.
Full screen, please.
So we start. Question number 1, regarding treatment of the first episode of nephrotic syndrome in children, all are correct. All are false except A, steroid to be given as 3 divided doses to reduce the adverse effect. B, hyponatremia does not need correction with 3% saline. C, while treating edema in nephrotic syndrome, dose of furosemide should not exceed 1 milligram per kg per dose. D, severe hypercholesterolemia should be treated with statins. Now, 10 seconds to answer this question. Okay, now we will go to second question. All the following statements about frequent relapsing nephrotic syndrome are true except A, 2 or more relapses in the initial 6 months after diagnosis. B, frequent relapse in nephrotic syndrome is characterized by 3 relapses in any 12 months after disease onset. C, long-term prognosis in FRNS is better than steroid-dependent nephrotic syndrome. D, renal biopsy is indicated in FRNS before considering alternative therapy. I will go to next question. Risk factors for adulthood disease include all the following except A, young age of onset, B, multiple childhood relapses, C, use of CNI or alkylating agents, D, hypertension at the onset of the disease. 10 seconds. I will go to fourth question. Percentage of food process effacement in minimatage disease is A, 50%, B, 70%, C, 80%, D, 100%. Most appropriate response is required. Now we'll go to fifth question. Steroid resistance is defined as absence of remission following oral prednisolone therapy of A, 2 weeks as per ISBN guidelines, B, 4 weeks as per KD guidelines, D, 12 weeks as per ISBN guidelines. Sixth question. Egg white is the preferred source of best quality protein for a child with nephrotic syndrome because of all except A, it is the only food item with protein digestibility corrected amino acid score of 1. B, it has a biological value of 100. C, it has a NPU, net protein utilization of 94. D, it has a protein efficiency ratio of 3.9. Next or last question. Regarding infections in nephrotic syndrome, all are true except A, child on steroids, alternate days after day may be given PCV. B, complement system disruption leads to impaired opsonization of microorganisms. C, spontaneous bacterial peritonitis is due to translocation of intestinal bacteria. D, a false negative TST is unlikely if done on the first day of starting steroids. Okay, now time for answering is over. Shall we discuss the answers?
Please do that. Please discuss.
Answer to the first question is B. That is, hyponatremia does not need correction with 3% saline. We had seen hyponatremia in nephrotic syndrome is often a spurious one because of the hypercholesterolemia. So that does not need a 3% saline treatment. Steroids to be given as 3 divided dose to reduce the adverse effects. In fact, we have seen single morning dose helps to reduce the many adverse effects. While treating edema in nephrotic syndrome, often we have to go to much more than 1 milligram per kg per dose. And cholesterolemia usually settles with the achievement of remission in nephrotic syndrome. So we'll go to the answer of second question. Susan ma'am, please discuss the answer of this question.
Yeah, so all the statements are true. One is false. That is what we have to find out. We know that the defining frequently relapsing nephrotic syndrome, 2 or more relapses in first 6 months after diagnosis, that statement is correct. Frequently relapsing nephrotic syndrome characterized by more than 3 relapses in any 12 months after the disease onset. That is also correct. And long-term prognosis overall in FRNS is better than SDNS. That is also correct. Renal biopsy is not indicated in FRNS before considering alternate therapy with Levamisole or Cyclophosphamide or Mycophenolate Mofetil. And CNI, when you start, currently we are doing a renal biopsy. So in all cases of FRNS, before considering non-corticosteroid therapy, renal biopsy is not indicated. So that statement is the wrong one.
Answer is D.
Answer is D.
So we'll go to answer of third question. Again, Susan ma'am, please discuss this answer.
Yeah, there is the adulthood disease is the risk for the disease going to adulthood is more for a very young age of onset. If the child is having the onset of nephrotic syndrome below 3 years and multiple childhood relapses are there, warranting use of alternate drugs like alkylating agents or calcineurin inhibitors, those 3 are situations where most probably there is a high risk of adulthood disease, almost 27 to 42%. That is what is in literature. And hypertension at the onset of disease per se as a single factor is not a risk factor for adulthood disease. So answer is D.
Okay, thank you, ma'am. And now answer of fourth question. Dr. Mahesha, sir, are you there to answer this question?
Yeah, here the podocyte foot process effacement in the MCNS, as we saw that it's more appropriate between the option C and D is the answer of 100% effacement. If it is there, then it is undoubtedly it's a minimal change disease. But if in the setting of very low albumin and if you are able to see more than 80% also, then we can say that it is falling in the category of minimal change. But the option D would be the right ones in this option.
Most appropriate one.
Yeah.
Okay. Thank you, sir. Now, the fifth question, steroid resistance is defined as absence of remission following oral prednisolone therapy of Anil Vasudevan, sir.
Yeah, so the ISBN says it's 4 weeks following steroid therapy when you document absence of remission. KDIGO guidelines actually says 8 weeks of steroid therapy. IPNA in the recent guidelines has said it's 6 weeks of therapy and absence of remission, and 12 weeks is never recommended by any of the guidelines. So even the new guidelines that are going to come up from the Indian Society also will be using 6 weeks of steroid therapy and then documenting an absence of remission to define steroid-resistant nephrotic syndrome.
The answer is C. Thank you, sir. Now, sixth question. Elizabeth ma'am, will you please explain the answer?
Yes, egg white is the preferred source because of these reasons, except I will start, because the answer is A, I will start from D. Egg white has got a protein efficiency of 3.9. That is something very good, and that is correct. It has a net protein utilization of 94. That is also correct. It has a biological value of 100. That is correct. And it is not the only food item with the PDCAS of 1. This is given as because it is the only food item. That is, even if there is only 20 gram of protein in 100 gram of egg, whereas there is 43 gram in soya. But and it has got a PDCAS of 1, but still we won't recommend because there is a weight limiting amino. So A is down.
A is the correct answer. Thank you, ma'am. Now the last question, the answer. Jason sir, please.
Yeah,
Jason,
regarding
sir?
infections,
Yes.
yeah. I think the alternative steroids we mentioned, PCV can be given once you go on to the daily, once you go on to alternative steroids because immunosuppression is less. And it's important that if you give them PCV as soon as conjugated pneumococcal vaccine, immediately after they go into alternative steroids, you have to repeat it after 3 months. And then that is something that we must ensure. That is something that we must know, but it is possible to give PCV as soon as you go into alternative steroids. Complement system, that is known, that it's a complement system disruption occurs, and that's why there's impaired opsonization of microorganisms. And when you give the MAN2 test, I said this, we take about a month for to get false negative results. So if you started steroids and you give a MAN2, it doesn't cause a problem. Usually you don't get false negative results. Spontaneous bacterial peritonitis has been something that has been, it's been a mystery for a long time. We don't know what actually causes it. It was thought to be translocation from the bacterial in the intestine that's going into the ascitic fluid. But now they think that it is more due to the immune compromised state, and it's a bacterial, the septicemic, the bacteria that causes the bacteria to get into the ascitic fluid, which has got very low protein. So the SAD is very for like for instance in cirrhosis and in ascites of nephrotic syndrome, the protein is very low, and therefore there is a higher chance of infection in and the organisms are not always gut. You have 1/3 of them are E. coli or and then the rest of are the capsulated organisms. So there is pneumococci and that can produce bacterial peritonitis and not only E. coli. So it's not only gut organisms. So therefore, it's not the translocation of intestinal bacteria, but it's a more it's actual cause is definitely still to be elucidated, but it's not translocation of intestinal bacteria as was thought earlier.
So we have found answers to all the 7 questions.
And I'd like Dr.
to
Donnie to
Johnny,
tell
sir.
us the results.
Yeah, so we have Dr. Arun Dua with 18 marks who won the quiz today. Dr.
Very
Arun
good.
Dua, who got 18 marks, 18 marks, and has won the quiz for today. Congratulations, Dr. Arun Dua. Can you please share your photo or your phone number or something like that, please?
Please share it in the chat box so that we can send you your certificate.
Dr. Arun Dua, 18 marks. Yes, I am
Nephrology, DNB, Army Hospital.
R&R. Congratulations.
Congratulations, Dr. Arun Dua. Now, I don't think there's enough time for questions. There's one by Dr. Rekha. She's asked Dr. Susan, what is the role of deflazacort? Is it any use giving deflazacort for achieving remission and for maintaining the child in remission? Deflazacort. What is any studies on deflazacort?
That is a nice question, Dr. Rekha. Actually, none of the guidelines recommend using deflazacort to induce remission in nephrotic syndrome relapses or nephrotic syndrome first episode. Actually, deflazacort is being used by many people for inducing remission, and what we have seen is it is the efficacy of this steroid deflazacort is much less than the prednisolone, as is its side effects are also less. But once you go for the less side effects, actually the induction remission time taken as well as the percentage of children who are achieving remission is not as good as prednisolone, and that may be the reason why the most of the guidelines, almost all the guidelines, will not consider or have not considered deflazacort as a molecule for inducing remission or during relapse remission or induction of remission in the first episode. And what we usually see is if you are having a steroid dependent nephrotic syndrome who is having the threshold dose is very low dose dependency. And as you are tapering and reaching the lowest level of prednisolone, that is 5 milligram on alternate day, sometimes we try to change to deflazacort 6 milligram on alternate day. 6 milligram of deflazacort is equivalent to 5 milligram of prednisolone. So such trial of using deflazacort for maintaining remission has been tried. And if the child is a very low dose steroid dependent, possibly sometimes we are able to maintain deflazacort to maintain the remission and reduce the side effect of steroid.
Thank you, Dr. Susan. There's one question by Professor Tambra for Mahesha that the DMS, can that be an old collapse?
I was just typing in the chat box. Like in the collapsing glomerulopathy, it's more for the residents here, the postgraduates. The collapsing definition is that of a hyperplasia of podocytes, which is at least 2 layers in the Bowman space with a collapse of the underlying tufts. So that defines the collapsing GN. Unlike in the diffuse mesangial sclerosis, it's usually the podocytes which are reactive with a cuboidal kind of appearance sitting on the basal membranes, and it has a crown-like appearance very next to each other with a completely solidified underlying sclerosis to the extent that it is almost global in nature. So only thing that you see is that of cellularity is that of podocytes which are crowned and the empty Bowman space. So the striking difference of the obsolescent glom is that of complete obliteration of the Bowman space in the solidified glomerulus. So these are the 3 differentials what we usually have in the glomerulus when we see at the obsolescence versus DMS. So hope this clarifies the doubt.
Thank you, Dr. Mahesh. Dr. Anil Vastavan, should immunosuppressants be continued in a child whom mutation is detected?
Sorry. So as I said, there is when a patient has a genetic mutation identified, these are all, most of them are structural proteins that affects the podocyte. So these immunosuppressive medications won't work, although some of the immunosuppression drugs like cyclosporine and tacrolimus has some action at the podocyte level, but they don't usually work. A small proportion, around 5%, have shown some partial remission to these medications. So that's why the recommendation is not to continue these medications once they have an identified pathogenic or a likely pathogenic variant in the child.
So what do you do? It is a symptomatic treatment test?
Yes, generally, because the risk, one is that these medicines are very expensive. They have a lot of side effects also. So obviously the risks are far higher than benefits. So putting them on supportive care will be the way to manage these children.
Okay. Dr. Elizabeth, how long should salt restriction be continued?
Can you repeat, please?
Salt restriction. How long do we continue salt restriction?
Salt restriction is to be done when there is edema and hypertension. But
the question is, see, there was a few time when not much salt restriction was advised. You're saying salt restriction for how long? Which is the cases where salt restrictions don't?
Most of them present with edema, and quite a few of them have hypertension also. So initially we put them on salt restriction, and then as the child goes into diuresis, the edema comes down, we can take it off. But in my experience, most of them relapse. And when they come, again we impose. And it is very difficult for a child to again learn that. So keeping them on low salt, no added salt can be an option when they are steroid dependent or steroid frequent relapses or with hypertension, etc.
What is the recommendation of the nephrology group regarding salt restriction?
So generally, we do restrict salt when there are definitely edematous, because a relapse status or someone with proteinuria is a very salt retaining condition. So in those circumstances, to ensure that the edema doesn't worsen. At the same time, many of the children are on diuretics. So if you give them salt, there is a post-rebound increased absorption of this salt from the renal tubules, so which decreases the efficacy of diuretics. So in an edematous child, definitely yes. And in children who are hypertensive, like steroid resistant, we do advise salt restriction as part of the management. But otherwise, in a steroid sensitive who is in remission with any immunosuppression, we tell them to take the regular normal amount of salt. But knowing that in general population itself, the salt consumption is advised to be low, we follow that advice.
Dr. Anil, Matthew, see, once you go on to, there are some nephrologists who, after when they go to after this the 3 days of no protein in the urine, you go on to an alternate day. There are others who go on to daily steroids for relapses. What is the difference?
Yeah, in the initial few relapses, we can try with alternate day therapy. But if the child is a frequently relapsing child, tapering on a daily basis is helpful. That is there in the new KDIGO guideline 2018 guideline. Daily tapering following for a frequently relapsing child is more useful in reducing
no, we're not hearing you. Can't hear you.
Using the future relapses, side effects. That's what. Hello, am I audible?
No, not so. Can Susan take that?
Yeah,
we can't hear you.
Can you hear me now?
Yeah.
Yeah. So when the child is frequently relapsing at a dose like 0.7 milligram per kilogram, alternate daily you are giving, and that is the found as threshold dose for the child. You want to give 0.7 milligram per kilogram alternate daily. That is one option. Second option is to give 0.3 milligram per kilogram daily. So when there is one study from Holiday Institute showing that this 0.3 milligram per kilogram daily given, which is equivalent to 0.7 milligram on alternate days, is actually found to be maintaining remission in a better manner than the alternate day therapy. But that is, there are only few studies coming up like that. And the KDIGO guideline is also now telling that the daily tapering may be better, and the alternate day higher dose can be made into daily a little more lower dose. But long-term effect of the daily steroid therapy on the growth of the child, we are not sure. We know that once we give daily steroid, definitely in the long run, the growth effect needs to be assessed before we really go on to such a final guideline. But the studies have shown that daily tapering is better in maintaining remission. So possibly more studies coming up and more robust guidelines we will be getting.
I think we got 73 chats, sir. There's been a lot of questions. I don't think there's enough time to go through many more. We're already 2 hours into the session. I request Dr. Narayanan here? Otherwise, Dr. Johnny to say a word of thanks, please.
On behalf of IAP Cochin and IAP Kerala, I thank all those who have attended this interesting update on nephrotic syndrome. It was certainly a very enlightening discussion, very active participation by all, and I hope everybody has been it has been a useful discussion and a meeting for all. I especially thank all the speakers, Dr. Anil Matthew and Dr. Susan Udup and Dr. Mahesh Ravi and Dr. Anil Vasudevan and Professor K.S. Elizabeth Madam and Dr. G. Sinoni, who are the speakers for this day. I also thank all the senior members like Tony Sir and all who have come for the meeting. Also Dr. Narayanan, who State President IAP, and I also congratulate the winner of the quiz, the winner of the quiz also I congratulate, and till Dr. Arun Dua, And yeah, till we meet next week with another exciting program. I declare this as being close for time being. Thank you.
Thank you so much, everybody. You were great. All of you were fantastic speakers. I think we've had a great discussion. Thank you so much.
Thank you all. Thank you.
Thank you.
Thank you.
you.
Bye.
Bye.